So hello and welcome everybody. I'm Julia Charlton, Chair of the Commonwealth Chamber of Commerce, and it's my great pleasure to welcome you to this special fireside chat with Dr. James Han Boon Kong. He's an esteemed surgeon whose remarkable career spans over 4 decades of dedicated service to the medical profession. So today we're going to have the privilege of hearing Dr. Kong's first-hand account of his recent volunteer mission to Butare, Rwanda, with the renowned non-profit organization Global Clinic. This Singapore-based initiative has been at the forefront of providing vital healthcare services to underserved communities worldwide, impacting over 35,000 people across 11 countries in Asia and Africa since its inception in 1997. Rwanda is a nation that's made impressive strides in socio-economic development since the 1994 genocide against the Tutsi, and it continues to face challenges, though, in ensuring equitable access to healthcare, particularly in rural areas where over 83% of the population lives. With only 0.7 physicians and 1 hospital bed per 1,000 people, the shortage of medical personnel and infrastructure is acute in some regions, including Butare, the focus of Global Clinic's latest mission. As part of a dedicated team of volunteers, Dr. Kong lent his exceptional expertise to provide free healthcare services, train local staff, and support infrastructure development in this underserved community. His participation in this mission not only exemplifies his unwavering commitment to the medical profession, but also his compassion for those in need, transcending borders and boundaries. Through this fireside chat, we'll gain some valuable insights into Dr. Kong's journey, reminding us of the power of individual action to create lasting change and improve lives globally. So it's my great pleasure to introduce our speaker, Dr. James Kong, this highly qualified and accomplished medical professional with prestigious fellowships from the Royal College of Surgeons in Edinburgh, the College of Surgeons in Hong Kong, the Royal Australasian College of Surgeons, and the Hong Kong Academy of Medicine and Surgery. His expertise and dedication have earned him the respect of the peers and patients alike. So please join me in extending a warm welcome to Dr. Kong as he shares his remarkable experiences from his surgical mission in Rwanda and his broader journey. Dr. Kong, over to you.
Thank you for this opportunity to share my experiences that I have recently garnered in Rwanda, and an opportunity to share my thoughts on healthcare capacity building around the world. This famous quote from Charles Dickens' Tale of Two Cities, best of times, worst of times, the age of wisdom, age of foolishness, reminds me of where we are today in the world, where seemingly for us in the developed countries or the high middle income countries, things are at the best of times. But in the low middle income countries, it is still the worst of all times. So my belief always that if we are going to do anything, we need to be able to help them fish, but not to fish for someone who is hungry, but teach them how to fish so that we are doing them a good turn. Now, my career in healthcare started a long time ago when I was training in the UK, and then coming back to Hong Kong, I worked in the public system for many years. On retiring from the public healthcare system in Hong Kong, I had the opportunity to work as a volunteer working in the low middle income countries. It started when I first went back to my homeland of Myanmar, which was originally Burma when I was born, to work there and the opportunity to help people there. Now, what I noticed was that in going to any countries, capacity building is all about step by step. This picture, the Chiang Mai Bridge in Hong Kong, is a demonstration of high capacity building in Hong Kong in 1997, when we were able to build this brand new bridge connecting up the highway to the new airport. However, places in Myanmar, which has started as a very at top of the world in terms of capacity building, with the medical school starting long before even Hong Kong had a medical school, today has quite considerable challenges. I believe that if you wish to help somewhere, there is 4 steps. You need to be invited, you must have local collaboration, and more importantly, there must be leadership locally which will lead this partnership that we want in providing help to someone. In Myanmar, the opportunity of the invitation came as a result of a tragedy. The tragedy was the 2008 cyclone Nargis in the Bay of Bengal, which, unlike most cyclones which go north and west towards Bangladesh and the Indian coast, went east towards the Irrawaddy Delta in Yangon. The end result of this was that there was a great demand, and Burma opened up and required capacity building. Now, capacity building is essentially two components: the software, the human education training, and then acquisition of hardware to support the capacity that these people have. In Myanmar, the invitation came from the Myanmar Medical Association, a well-established organization pre or around the time of the Myanmar independence, and where they did analysis and realized that they needed better training in terms of skill development for developing emergency care. So we wanted to provide them with the ability to build capacity. The end result was that a team of us, led by the Australasian College's leadership, we went to Yangon and in 2009 developed a primary trauma care, what I call a beggar's version or the poor man's version of the advanced trauma life support system that is now currently utilized in many parts of the world. Nevertheless, one of the problems in Myanmar is that, like anywhere else, things have to be lined up in the dark. In medicine, we recognize that when things line up in the dark, that's when hazards line up and we have a significant failure or a patient's death. And in Myanmar, the things line up because the half bridge built, the opportunity came about with the 2008 cyclone and the development of the world's mobile system and so on. People started wanting to have more things to be done. And as such, the National Consensus Workshop for the Development of Emergency Medicine was finally gathered in Yangon at the behest of the ministers. And this is a picture of all of us getting together to develop a consensus on how to develop medicine in Myanmar. Overnight, literally within weeks, we had a letter of intent between the ministry and the international community, and we were able to develop emergency medicine. How do these resources get on? Well, there are people queuing for care all over the country. This is a picture of people queuing for cell phones, but the same thing appears in the hospital corridors of Myanmar, Rwanda, and many places around the world. This development requires the ministries to collaborate with international groups to do things. Now, in Myanmar, we were fortunate able to build up to now over 36 resources of emergency physicians who are now able to provide care in the country. These are well-trained and qualified people. Through an international collaboration, we were hoping to develop further educational skills and training center. So, where does Rwanda fit in? Well, Rwanda is a landlocked country where teaching fishing would be interesting, but I had the opportunity to join them on their 10,000 miles journey to go and develop the community care. It started last December when Dr. Myra Elliott, a retired facial maxillary surgeon, came to Hong Kong and invited me, a strong woman, a strong lady. She invited me to go and join her team of Singaporean and Malaysian physicians to go and work in Butare, Rwanda. But the first thought of Rwanda I had in my mind was that I was going there to see gorillas in the mist. Unfortunately, I didn't have that opportunity, but I had the opportunity to work with this team and with Dr. Etienne Gurat, the chief of the ENT surgery in the country. When we were going there, I asked what help was I going to do, and I realized that from the email that they sent me, they were asking me to look after difficult patients with very difficult, and what would be even in Hong Kong or in the developed world, a difficult breast cancer cases and hugely difficult neck thyroid problems. So with that, my brother, who is the anesthetist, and I went to Rwanda and visited CHUB. CHUB is the second university teaching hospital of Butare, where they provide a wide spectrum of services. This picture in the middle shows the Genocide Memorial of 1994, where all the doctors and nurses who died, their names are on the panel. It's a beautiful countryside. The hospital has a cafe sitting out in the hillside, and it's a wonderful place. However, the struggles they have in terms of providing care is really a challenge. We went there, the operating theaters were equipped, but I would say by our standards, relatively bare. Equipment-wise, they had very little equipment that were needed for what they needed to do. And here's a picture of Myra Elliott donating dental equipment for the newly trained dentists in the country. One of the things we found was that things are not well resourced. Resources are poor, and moreover, the organization was also poor. Although they had skilled people trained, there were a lack of skilled staff, and therefore, as a result, people were working day and night without much help, and we felt that what we could offer them was proper training and system development. One of the remarkable things I noticed in Rwanda was that there was literally the lack of poor people begging in the streets, which you would expect to see in a country in Africa, which we did not see anywhere at all. And the roads were spotless. And this is repeated wherever we went. We brought some basic technology. With the advance of laptop computers, we were able to show them how to create and use mobile graphic systems to help them plan their surgery. We're able to show them and teach them, and they were very, very receptive to this thing. Again, another picture of how it is spotless in the street. We demonstrated them. One of the things we took them was this mobile little USB charge headlight, which helped them as their operating theater lights had only 2 out of their 3 bulbs not working. So we were able to spend time teaching with them and sharing our leadership with them. Here is a picture of us being thanked by the chief of the hospital, and on the other side, a public health message. Young children were given coins by visitors, and the young child, not knowing what the coin was, swallowed it as though he thought it was a sweet, and we had to retrieve it from his trachea, his airway. Truly challenging things that we have to do there, and this is some of the things we saw and learned. Thank you.
Thank you so much, James. That was wonderful. So obviously there must be a million stories you have, not just some child swallowing a coin. That seems unfortunate, doesn't it?
Yeah. Unfortunately, we actually saw 2 child swallowing coin in the same day.
Oh,
and
my
it seems
goodness.
it's a very common public health problem in Rwanda, that visitors will give children coins as though they were giving them a gift, thinking that giving them a coin will be something useful and for the child, and children not knowing what coins are, and they are never given, nobody gives money to each other because the poverty isn't that. But when visitors see young children running around the street, they think they want to reward them, they give them a coin.
Yeah.
And the result is that the doctors are constantly having to fish out, and it is apparently 2 to 3 times a week at the hospital. And these are people in the town.
How long does it take you to fish a coin up?
So that took us a good hour of work, because anesthetizing a child is extremely difficult, especially if his airway is compromised by a coin in the middle of it. So this is a public health problem and a major issue.
Oh my goodness. So they need to have education on not swallowing coins. My goodness. Yeah.
And visitors not donating coins.
Yes, more to the point. Absolutely. Yeah. So James, that was so interesting. So let's start off. You mentioned your brother. So how about your family? Are you from a medical family? Can you tell us all about that?
My parents were both doctors and passed away. My mom was a first female gynecologist obstetrician in Burma. So she led the troops throughout the whole her whole career and throughout her whole life, and three of us followed in her footsteps. Two of my brothers are anesthetist intensivists. One is working in England and one is working in Singapore. And that's how I came to be involved with this Singaporean group, since I spend most of my time not in Singapore, but more in Hong Kong.
Right. So that's amazing. In fact, your whole family's dedicated their lives to being doctors.
All three of us were meant to be in Africa this trip, because previous year, two of my brothers went to Africa, to a different place called Lesotho.
Yes.
And this year, all three of us were meant to be together. Unfortunately, my second brother had a back injury and ended up in bed and could not get out of bed. I unfortunately had a knee injury, or injury to my right leg, but I went with my crutches and braces because I couldn't find a replacement.
Very noble of you. So what made you decide to pursue a career in medicine, other than the fact that your family was involved in the medical field?
Probably we all the brothers had to pursue a career in medicine, partly because the only way we could be as good as our parents were to be at least in the same field. Otherwise, if we were in any other field, would have been considered that we were a failure and not as good as our parents.
Right. So it wasn't some great calling to help people as a doctor.
Well, at the time when we left Burma and as teenagers and just going to school and starting university, none of us knew anything else. We only knew the career in medicine because we saw our parents looking after people, and we got sort of emulated to try to do things they were doing. And that was the first initial impulse of us going to medicine. It wasn't really much as, although we knew that our parents had a huge following of patients and friends from there looking after them, we never thought of it as something that we needed to do. We just felt we need to be at least as good as our parents, if not nothing else.
Right. Continue
Calling to do other things came much later as we went into our career in medicine.
So what made you decide to specialize in surgery?
Well, surgery was another one of those careers that I decided not to be into. I wanted to do intensive care, like my two other brothers, who are all both in intensive care, because we felt the need to be there at the forefront looking after critically ill patients seems like a challenge, and to be able to succeed when people were critically ill. But I couldn't get into critical care because the training system was such at that time, there wasn't a set formula or a pathway for critical care, and I just couldn't find a way into critical care. I ended up doing surgery, which was to me second best to critical care. My two younger brothers, however, felt they wanted to be in critical care and succeeded in finding a pathway, because by their time, a few years or quite a few years later, the pathway for critical care training was well established.
Right, right. So a lot of doctors focus their careers on private practice, and that's obviously not a route that you've gone. So what led you to spend so much time in public service, and in particular dealing with underserved communities? Because we heard about Myanmar as well as Rwanda.
My public health career was more focused on a completely different pathway. I was interested, after doing a surgical career, I was interested in auditing surgery. And my career went into informatics, or health information management, which came about because of my interest in audit. I designed audit systems, or PC computer-based audit systems, in the late 80s, early 90s, when personal computers has just become to be available and cheaply available and in vogue. I got involved with auditing and designing software to audit. From that came about hospital information systems, which was a subsequent follow-on from individual auditing of a department into auditing or managing the hospital. From that, I ended up implementing a hospital information system in a Christian charity hospitals in the early 90s. And then when I joined the public system completely, the Hong Kong Hospital Authority, I ended up being involved with the clinical systems that were being developed at that early stage of information management. During the SARS 2003 episode, I volunteered and ended up helping the headquarters develop an epidemic management system called the SARS ESARS management system. As a result of that, I was head of the public hospitals for IT for a few years, and when I resigned and left the public system was when I started looking at capacity building. Throughout my 20-year career in the public health system, I didn't realize I was looking at capacity all the time, from IT, hospital management to hospital commissioning. I was constantly looking at commissioning systems and looking at how to improve systems, which in a way is what capacity building is all about. So when I resigned and retired and went off to Myanmar for a visit, my first time back in 30 years to my homeland, I was initially involved with the development and commissioning of private hospitals there. Having helped them commission the hospitals, Cyclone Nargis came about, and the opportunity to work with the local community, medical community, in a bigger way came about with the developing need for emergency care. Emergency care is not a development, it's been always a need, but there has never been proper emergency care structure system in Myanmar except hospitals, which were formed more like MASH, Mobile Army Surgical Hospital. People just appear at the hospital, line up, and hope someone will look after you. The structured emergency care came about because as I helped them build skills in emergency care, we realized that there was no way you could just have skilled people. You still needed a system, an environment that is managing emergency in a very structured way. Otherwise, you just have chaos. So I sort of naturally gravitated back to my capacity building in the public system and looked at capacity building in the Myanmar public system.
Mm-hmm.
So I started working with other people who were interested in emergency building and people who were interested in the skills training and people who were interested in system development. Myanmar was an advanced medical center in the early 1990s, 1930s, 40s. It was one of the premier medical schools in Southeast Asia. Unfortunately, with the changing times, the medical system had deteriorated in the sense that the systems was poorly resourced, and therefore there was considerable challenge how to provide care. But even in poorly resourced places, I believe that well-organized care still can improve the local situation. So I was lucky to meet doctors, professors, managers in the system who were interested in building capacity. So that's how I came about building capacity. Working with them, I went to train people, teach them, and then help them to manage what I call 4 yeses. 1, yes, I hear what you're telling us to do. Second, yes, I hear and understand what you would like us to do. Yes, 3, I would like to do what I hear and understand. And finally, the cultural change of yes, 4. So in Myanmar, we were able to get to 4 yes level, telling people that you need to change. This is how you change. They believe that the change will be worth their while and they will change their culture. So that's how I came about working in sort of from public system to another public system, trying to improve systems around the world.
So what sort of, if you had to put a percentage on it, you know, what percentage improvement do you think there was in Myanmar during those years when you were able to be working on that with others?
Well, put it from the point of view, let's look at emergency medicine. When I went to Myanmar in 2006, there were people working in emergency care, but there were no trained emergency medicine specialists able to focus and direct care properly. By the time we finished our 2 training projects over the 6-year period, we had 36 people trained as emergency medicine specialists who could continue to train others.
Mm-hmm.
And they established their own training program by the 6th year to run their own master's program in training. So that's the route of expansion. That's, in terms of percentage, it's hard to say, but it was 0 before we arrived.
Right.
Now we have 36 people, and that 36 people will in turn breed others. So that's the sort of the crucial jump.
So now, are those programs continuing now, those training programs?
Some of them are,
Myanmar?
even though people are dispersed around the country, these people are now the seeds for others to develop around them. So these things will continue to develop, but obviously peace is necessary to help this thing flourish in a big way. Resources are necessary, investment is necessary all around to make these things expand and expand exponentially.
Yes, yeah, yeah. So that's fascinating. And you must be disappointed you're not able to go there at the moment.
Well, at the moment, I'm still collaborating, well, through the internet and through the technology media. We can still help them in one way or the other.
Right, right. Still provide support. That's great. So, apart from Myanmar, what are your other rewarding journeys, do you think, during your career?
So for Leighton College School, I'm a fellow and director. I have a number of work with them in the past. I've been to Papua New Guinea to help teach courses there and lead programs there. I've worked in the Pacific Isles with my colleagues from the Australia, New Zealand, going to the Pacific Islands of Fiji, Tonga, and provide training and education there as well. So those are the sort of Pacific side of things that I've done. Rwanda was my first foray into Africa. After my brother's visit the year before, they felt that they were going to go back there, and the Rwanda government kindly invited Dr. Mara Elliott to bring a team there. So she brought a group of us, surgeons, gynecologists, physicians, as well as a large contingent of orthodontists, orthofacial maxillary and orthodontists, dental people there, because Rwanda last year had just graduated its first batch of dentists locally, but they were extremely short in terms of long-term specialist training. They just barely graduated, so they wanted a bunch of experience, or they wanted like a team of experienced dental surgeons from international level to come and oversee what they're doing and advise them on how to progress from there. So that's why the large contingent of the group that went was mainly dental, facial maxillary people.
Right. So did you have a particular motivation other than the fact that your brothers were going and so on to volunteer your skills for the clinic?
Yeah, as I was not going in Asia, and sort of the pandemic kind of stopped travel, particularly because I was stuck in Hong Kong and couldn't leave. I didn't want to do hibernation in hotels. I didn't travel very much during the pandemic, and this was the first trip, essentially after the pandemic, to go and help other people.
Yes.
And as Dr. Mariella turned up just as the doors opened in Hong Kong, and invited me, I felt that was an opportunity to go and see what they were doing there and how they could be helped. I had no idea the actual on the ground situation of Rwanda healthcare, other than the fact that they were organized, because I had been there about 6 years ago, 2 years before the pandemic, to visit the other medical school at Butaro, which is set up by Partners in Health from USA. They established a third medical school there, and I visited there at the time of its opening. So I was interested and keen to see how Rwanda was developing in terms of healthcare capacity.
Right, that's great. So how did you just prepare for this trip? How do you get ready to go on a mission like this? Are there details, and, were you apprehensive of anything?
Firstly, as I said, an invitation is necessary. You need to be invited by the local community, and the invitation requires us to have some clear ideas of what we were there to see or what we were there to do. Now, we knew that when I was going back there, some of the things that we wanted to do was to teach, but more importantly, we wanted to also be able to figure out what exactly we are going to teach them in. And the first thing was being a head and neck specialist and working mainly in thyroids and so on. I wanted to know if there were patients that needed care in my sphere of arena. So we discussed and communicated with the local senior specialists to find out what they were doing, what cases they had, and then what resources they were short of. One of the interesting things was that most times when we go on capacity building trips, we tend to take anything that's left over in our hospitals in the highly developed countries, expired syringes, needles, gloves, and so on, in the hope that they can be utilized in low middle income countries.
Yeah.
But Rwanda had a very specific regulations that please do not bring expired equipment for our people, because we do not want them left here and something and is utilized and something goes wrong, which was
Yes.
very admirable of them and very foresight, a lot of foresight in the way they structured this, which many countries don't. And international mission trips often bring expired equipment which may be not safe or inappropriate to be used in these countries. So we had to find donors to find and buy things that we needed for the country through donations, and such that we could buy new unexpired drugs, whatever else that is needed there to be taken there. So that was quite a challenge for us, because first, not only were we giving up our own time, we had to raise funds. So a lot of the funds were actually raised by donation from the team ourselves, in the sense that we bought and acquired new unexpired things to go, which quite unusual compared to normal trips when we would just go to hospitals and to the staff and say, what's left over, what's been thrown away, okay, put them in the box, give it to me, I'll take it there.
Yes,
This
yes.
was an unusual preparation in that sense.
That's interesting. And what about you personally? Was there anything you were particularly apprehensive about, not knowing exactly what you were expecting?
Well, going there to teach is one thing, but going there to help them operate on cases was another thing, because one of the first thing I had was the challenge of, when you're operating on a critical patient, you usually need a team of people that's used to working with you. In Hong Kong, most places I work with, I would have my own scrub nurse, my own anesthetists who are used to working together and will have time to plan and prep the operations.
Yes.
But going to somewhere near to that, when we didn't have anyone of your usual team, that would be a challenge. So fortunately, on this trip, my brother, who's a senior anesthetist and intensive care specialist, was with me. So I knew that at least from the anesthetic point of view, things were safe, in the sense that I could rely on him to help things. But still, it was quite a fear, because I didn't know whether I was going to be operating with a scrub nurse that knew what I wanted to do, how to want to do it, and I didn't have the instruments. And I couldn't actually carry a suitcase of 100 pounds of instruments over there, and not knowing whether they'll be allowed in, whether they'll be sterilized, because we were told that any instruments then had to be imported officially, and we had to write for permission. And in fact, there was a sort of 20-page bureaucratic application that we had to submit, and for some of the things we're donating there, and luckily, or whatever happened, when it got to the airport in Kigali, nobody asked any questions, and they didn't want to see the papers of the application we had submitted, the permission that we had applied for. We just walked through.
That's good. That's good. So during your time there in Butare, tell me about the place, and how did you find it? What were some of the most eye-opening stories, and perhaps some heartwarming patient stories that you came across?
Kigali is an international city by many standards, with skyscrapers. It's built on multiple hills, but we spent very little time in Kigali, in the sense that the chief of ENT met us, and we were put on a bus ride for 5 hours to Butare, which is 5 hours south of Kigali.
Yeah.
The roads were a two-lane road, one going one way and the other coming the way. There were no highways throughout the country. But what was interesting was that the road was impeccably smooth. There were no potholes, no rubbles, and for a low middle income country, it was quite a well-made, high-level highway by any standards.
Right.
What was more interesting was the fact that the pavement on each side of the road was almost as well made, because it seems President Kagame said that the people had to walk everywhere, and in fact, people walked everywhere. There were shuttle buses between cities, but for most people between towns, they kind of walk every day.
Right, right.
And the pavement was well made to the point where you could walk as comfortably as you could go on the road. So that was one of the things. The other thing was the fact that the country was spotless. The country has a Keep Clean Saturday once a month, where everybody stop work, open their front door, sweep the whole house, sweep the driveway, sweep the roadsides, and the roads were then spotless. And they maintain it every day throughout the whole month, that the place was kept spotless. So even if you went down a back street which was bumpy and hadn't been paved, the road did not have rubbish and piles of trash lining the road. It was quite a shock having the experience from Myanmar, where if you go around every other corner of Yangon, there were piles of plastic, a mile high, 10 feet high, 20 feet high of takeaway boxes that people had thrown out and been swept to the side of the road. There wasn't a single takeaway box to be seen, and I found out the reason there was no plastic was the fact that the country had planned the use of plastic, and paper bags was the rigor, the mandated that you had to use paper boxes and paper bags, and recycling was quite a normal thing for them. So it was remarkable to see the improvement since. It was just as similar to when I first visited 6-7 years ago. The place was clean and spotless. There were no piles, despite the progress in the economy of the country. There were no piles of plastic, which I kind of associate with low middle income countries around the ASEAN, where everywhere you go, as the progress and economy improves, the piles of rubbish, plastic rubbish particularly, gets higher and higher.
Wow, that's impressive, isn't it? It sounds like
yes, that was the most
doing a
impressive
good
part.
job.
I believe that the people were serious about it, and they had the culture in it that they would keep their place neat, tidy, and clean.
How interesting.
Which is I've never seen in my travels in the Pacific or
Yes,
Asia.
interesting. Yes. So tell me about some of the patients that you encountered. How were they?
So I showed the picture of the little kid's chest X-ray where there was some little white thing in the middle of his airway, and that is I didn't realize it was common until I talked with the local surgeons, and then they realized that when we were doing this case as an emergency, I was helping. I thought, this is really strange and unusual. And in my experience in Hong Kong, we fished out foreign bodies from people's airway. But in my 10-year career in the public hospital, in the teaching hospital, we barely done 10 in 10 years. We do 1 or 2 a year as a unusual thing to find, but this was apparently normal in the sense that this happens every week.
Goodness.
And so I said, well, you probably need to do a public health education. He said, yeah, well, we have to teach the visitors, and that's hard because telling them not to do something is all very well. They read the news, read the signboard, but they still do it anyway.
Yes.
Change the culture of the visitors hard. So I said, well, teach children. Well, 5-year-old kids are hard to teach. We give them something shiny, they put it in their mouth.
Yes, yes.
So,
yes.
so the public health problem is to do with the visitors, not with the locals. So that was the first challenge I saw. Second thing was they have a lot of advanced cancer, partly because people can't get to hospitals. The lady who's the email I showed with her breast cancer problem, she'd been waiting 6 months before she had to trek 2 days to come to the hospital. So a lot of access problems in getting to hospital, even though the country has roads, people are poor, they don't have money to take a bus, so they walk.
Yes.
Then once you see them and want to give them treatment, they can't afford, although there's free hospital care, the hospital doesn't have enough beds to keep everyone in the hospital, so people have to camp out in the grounds of the hospital. And that's something I've seen in the Pacific Islands too, when people have difficult access problem and come to hospitals. At the end of the day, when treatment program has started, in between treatment programs, they can't afford to go home, so therefore they just camp in the gardens of the hospital. Fortunately, the hospital grounds are spotless, the grass is green and is soft, so people can pitch up a tent and just live in the grounds. But it is quite a challenge from what we would normally see.
Goodness, yes, interesting.
So that's the thing, access problem because of poverty and unable to go and get the treatment. And then finally, the other thing is access to drugs. Chemotherapy, as we know in the modern world, is an expensive medication which does provide can provide treatment cure for patients, but this availability is a challenge even in Hong Kong for many people. And the public systems can't afford to give all the best chemo or the top, the latest chemo. And in Rwanda, that's even worse because these are beyond the affordability of even the public system there. And so those are challenges that they face.
Right. And how was the general health of the people you saw?
Overall, I think Rwanda's in good stead because I don't see fat people, no obesity. Therefore, the likelihood of, and the people walk, so therefore they have a lot of exercise. So they are not overweight. So one of the modern things that we will see in the high middle income countries of hypertension, obesity, heart problem is not as such a great critical issue. And
Right.
sugar, I don't think they've banned sugar yet, but their use of sugar is not so high, such that we will be seeing diabetes and so on, that we are now seeing in the high middle income countries around the world. So,
Yes.
in
Yes.
that sense, they are healthier. Nevertheless,
Yes.
they're endemic problems. So we saw patients with a lot of thyroid problems, which are endemic because of the lack of iodized salt in their diet. So until those public health measures are taken, we're going to continue to see people with endemic diseases which aren't able to be managed so successfully.
Right. Right. And are there public health programs which are dealing with those as far as they can?
The government has had a active program all around to deal with all sorts of public health in terms of infectious diseases and so on. Vaccination is a large and well accepted program, unlike many other places around the world. So, in that sense, the government is actively managing its public health crisis. The challenges of the health system now is more about dealing with the sort of advancing problems of systems, in the sense that the resources are limited. So unless the systems improve in their effectiveness, it's going to be hard to provide care equitably all around.
Right. Right. So, what are the most challenging aspects of the surgical care, do you think?
I think skills training is not uh, it's not the biggest issue. The station is having enough resources that can be put into skills training. So, in other training enough doctors so that there's enough staff to go around for the needs of the country. But the
Mm.
patient to doctor ratio is still very community. The population to doctor ratio is still very poor, and so more young people need to be trained to become doctors and health professionals in all levels. And then some of these need to be trained to be able to be better managers. It's easy to train someone to be a technician, it's harder to train someone to be a leader and a manager, and those sort of training is critical. And until people who have clinical sense and clinical knowledge willing to be trained to become managers and leaders, the systems are always development is always going to be challenging, and that's the big challenge for them. First is training enough resources. Secondly, training enough leadership.
Right. Right. And do you see that being worked on?
No, I don't think that's been worked on effectively. Yes, they have a few bright young people who will be, I can see potential to be leaders, but I don't think there's enough. And then
Right.
the medical schools, now that they've expanded to the three medical schools, are a start. But unfortunately, that's still a long way to go in training enough health professionals all around.
Right. Right. So, how do you think the impact of Global Clinic's efforts are in improving healthcare as a sort of program?
Global Clinic is one of the many organizations around the world providing help to low middle income countries in terms of the healthcare need. The easiest way to provide healthcare need is to help them fish, which is
Yes.
what Global Clinic has been doing, and in some ways to provide them teaching of how to fish. But overall, until world organizations are prepared to lead programs that will lead an organization in the whole system of care development, I don't think we are going to solve the healthcare problem or help the world healthcare problem in a big substantial way. Global Clinic fills a niche as part of a keystone to building healthcare systems, but we need a bigger and more concerted effort to bring together organizations to help in putting together a program to develop better, better care services.
Right. Right. So this volunteering in particular, was there particular challenges that you felt with it personally and professionally?
Um, well, I'm at the stage in my career where clinical work day to day is only a part time, and volunteering is a major component of my day to day work, and that's relatively straightforward. More challenging are for people who are just in the prime of their career, where they should think about starting to volunteer, because these are the people who will really make a difference in the world healthcare demand, in the sense that they have experience to with the technical skill to teach the skills, but
Yes.
also enough experience to understand the system to help improve systems around the world. And for these people, there don't seem to be that many people willing to go yet at their stage, and we need more of these
Yeah.
people to go.
Do you
We
think that could be encouraged through programs at particular hospitals and
Well, colleges,
encouraging
the
people
Royal
to?
Australasian College has a good global health program where it invites people to go. And the Royal Australasian College focuses its development, global health development program mainly in the Pacific arena, because that's where its base is.
Mm.
Um, the colleges in Hong Kong, Malaysia, Singapore, Thailand have programs that essentially focuses much on the local environment only. We need a broader pan-ASEAN development movement that will help communities in Laos and Cambodia, in Vietnam, and so on, because these are places which substantially need help, and they are not getting it because we don't have a pan-ASEAN healthcare development organizational group. The Royal Colleges of Thailand, the College of Academy of Medicine of Malaysia, Singapore, and Hong Kong should come together to work collaboratively to run programs across the region. Of course, China has significant demand needs, and Hong Kong is helping significantly with China. But that alone will swallow up most of the capacity that Hong Kong has to help.
Right.
So it is a challenge for around the world to get people going. There is a huge demand in capacity building needs in healthcare around the whole world, and we just don't have enough people volunteering.
Do you think there would be scope for the Commonwealth to do more? Because I mean, some of the countries you've mentioned, for example, Australia, Papua New Guinea, Singapore, Rwanda are all Commonwealth countries. And obviously, both Hong Kong and Myanmar have got similar backgrounds to a lot of Commonwealth countries in the sense that they have had British administrations at various points. So I wonder if you think there would be scope for a Commonwealth initiative for capacity building in hospitals and healthcare.
Well, healthcare development is firstly professional resource development. And these are essentially those of the Academy of Medicine or the colleges of surgeons or colleges of physicians and so on. Nevertheless, there isn't a Commonwealth approach to healthcare
No, but
resource
there's a sort of slight similarity of approach of countries which have developed in different directions, but have, for example, they all have recognizable institutions amongst each other, like colleges of surgeons and things like that. There is a similarity of approach to some extent.
Yes, but unfortunately, most of the Commonwealth institutions individually, colleges in each country, are focused mainly on the development of their own
Yes.
local needs.
Yes,
And
that's why I'm just raising this as a possibility for countries who sort of quote unquote speak the same language.
well, if you look at Australasian College of Surgeons,
Mm.
its main focus from its membership point of view or its fellowship point of view is that it needs to focus on the development of its own self before it has a small section called the Global Health section.
Mm.
Now, the Global Health Initiative, there are some global health surgical initiatives coming together slowly, but it's not Commonwealth, it's an international thing. And that's slowly coming to being because surgeons around the world, like me, are recognizing the need that development of global surgery as a whole is critical. And that's a collaboration already started. The Commonwealth itself hasn't got one on itself. However, in East Africa, for example, where Rwanda is, there is the East African College of Surgeons, which is being supported by the Royal College of Surgeons of England and the Irish College of Surgeons and so on. So there is some initiative there working with the local East African College Union. The East African Colleges consists of a number of East African countries where there is a conjoint exam, conjoint training, and so on. So there is some collaboration there in actual surgical training of surgeons. That's a start. If more collaboration from other Commonwealth countries were to come along, I think that will be a big, substantial improvement in the way systems could be developed.
Right, right. So of all the places that you've worked and traveled, which was perhaps the place that left the deepest impression on you? And this is a personal thing rather than a medical thing, perhaps.
I think Rwanda has just made a big impression because I never expected it to be clean, spotless, plastic-free, which in the present day of environment and climate change, I think is critical. And I wish more countries had the foresight and the willingness and the drive to achieve what Paul Kagame has done for his country, because that will be a great start for many of the low middle income countries around the world. From that, at least, will be a start towards developing the country in a better sense, and bringing the country up. And in that sense, Rwanda has recently made an impact on me. The other impact is Myanmar, of course, because I've spent the past 20 years working there, and now the chaos and the country being what it is quite sad to see. But I'm hopeful that peace will come, and we can look forward to renewing work there and trying to help them develop back to a level where it can provide care for its community.
Yes, yes. So you've obviously had a very positive impression in many ways of Rwanda. Do you think that, the recent tragedies there have impacted Rwanda in the sense that you feel the impact of them now, or do you think the country's moved on from that?
Do you mean that of the
genocide? Yeah.
Well, I visited the Genocide Memorial. It was sobering, very sad to see that genocide wasn't just the 1994 genocide. The genocide had been happening in that area for much before then, for a while. And 1994 was the peak. I believe, however, that that has passed. Although Rwanda, there are signs of instability or concern for instability when you see people at the airports checking the security checking is quite thorough, and long before you get to the airport itself and so on. And the people talk about it openly, that they're still concerned that uprising may come from across the borders and so on. So there is concern, but I believe in looking at the country that they are stable now, or they're going to keep it stable. There are attempts to make it move forward in terms of and development. You can see that the country has grown rapidly economically. So I'm hopeful that that has gone past and is unlikely to recur. And whatever instability that might be instigated from nearby is going to be watched for and cared for so that it doesn't happen. So I'm hopeful that Rwanda, I believe Rwanda has passed the challenges of the genocide and they are now moving ahead.
That's good to know. So do you plan to go back there, or, what's your next big medical adventure?
Well, I guess I wait for the next invitation, so to speak. And I've had an invitation to visit. I haven't had an invitation to collaborate. I need an invitation to collaborate with anyone in order that, and then the leadership wishing to collaborate is the next step I'm looking at in Rwanda. But in terms of other places, again, I look forward to the next invitation.
Well, thank you so much, James, for sharing all of these great experiences. I'm sure we could have talked for a lot longer. And thanks also for your insights about the medical mission with the Global Clinic in Rwanda. And it's wonderful to hear firsthand about what's really happening on the medical scene in Rwanda. I think we've heard a lot about the challenges and rewards of providing healthcare services, and in particular, trying to train the local medical profession to help underserved communities further. So as you've highlighted, I think Rwanda has made impressive socioeconomic progress since the 1994 genocide, but 40% of the population still apparently lives below the poverty line. And obviously those are quite sobering statistics across Africa and Asia, where Global Clinic operates. The World Bank, in fact, estimates that across sub-Saharan Africa, there is a 89% deficit in healthcare workers required to provide basic services. And in parts of Asia, up to 97% of the population lacks access to safe and affordable surgery. So clearly, what Dr. Kong has been doing in training local surgeons is of enormous importance. And organizations like the Commonwealth, with a global network, can play a role in bridging healthcare gaps through partnerships with non-profits, facilitating knowledge sharing, raising awareness. The Commonwealth potentially could catalyze solutions to enhance medical access worldwide, but perhaps that's something which needs to be further worked on at the moment, as we're hearing from Dr. Kong. And Dr. Kong, thank you so much. I think your participation really symbolizes the ethos of so much selfless giving. And you're really a champion of training skilled medical volunteers. And it's wonderful that you're doing so much to help and serve. And, you know, some of your stories, I hope, have inspired others to look at areas of service. I mean, whether they're medically trained or not, there may be areas where people can contribute. And I do think that the lesson that we've learned from listening to Dr. Kong today is that training people to train others is a much more sustainable and meaningful approach than simply, as Dr. Kong puts it, is teaching people how to fish, teach others to teach people how to fish. So I do hope you'll find this an inspiring webinar to have listened to, and perhaps you could look at your own areas of skilled volunteerism by any means possible. So thank you all for joining us for this insightful fireside chat. Thank you again to Dr. Kong, and goodbye, everybody.
Thank you very much.